in this symposium two presentations, short presentation, one on amyloidosis, on ATTR, and one on COPD. So basically, Dr. Ashab already has summarized what I'm going to talk. So basically, I'm not a pulmonologist, but because I deal with heart failure, and there is always this overlap, and the question comes always, is it an acute heart failure exacerbation or an acute exacerbation of COPD? So COPD in general is prevalent in around 10% of the worldwide people, with it's the second most common cause of emergency visits in most countries. It's estimated that more than half of the patients with COPD are underdiagnosed, which is important too. And patients with COPD die from both respiratory and non-respiratory, mainly cardiovascular causes. This is what Dr. Abdullah has alluded to. So COPD is the third leading cause of death worldwide. This is just in the publication that Dr. Abdullah has alluded to, just to show you the estimated direct medical cost and indirect cost of COPD in the UAE. And you can see the numbers are really very, very high. Like the total estimated annual productivity losses is around 22 billion. Total estimated direct medical cost is around 4.3 billion. So COPD patients in working or in being hospitalized, they really cost a lot in the UAE population. What are the prevalence of comorbidities in COPD? There are cardiovascular comorbidities as well as non-cardiovascular comorbidities. Cardiovascular comorbidities can include dyslipidemia, hypertension, ischemic heart disease, and heart failure as the most common, and others like diabetes, arrhythmias, strokes, aortic aneurysms, and DVT. And there are multiple non-cardiovascular comorbidities that I will not go about. The prevalence of cardiovascular disease in COPD is also important. Let's say 60% of the COPD patients had at least one cardiovascular disease, but around 30% they have two or more cardiovascular disease, and around 20 or 15 to 20% they have three or more cardiovascular disease. 20% have coronary artery disease, 20% have heart failure, in addition to around 10% they have stroke. So it is very prevalent. And that's important too. COPD can affect the mortality and increase the mortality of cardiovascular disease like heart failure, ischemic heart disease, arrhythmias, diabetes, and pulmonary hypertension, and vice versa. These heart failure, atrial flutter, ischemic heart disease, etc., can increase the mortality in patients with COPD. So major adverse cardiovascular events are a major contributor to overall COPD disease. And actually, COPD has been identified as an independent risk factor for cardiovascular disease, where around 1.9 and 1.4 increased risk of cardiovascular disease in men and women, respectively. And actually, the impact of exacerbation of COPD is 10 times increase of cardiovascular events or cardiovascular deaths within 7 days after discharge. So this is very important. Multiple patients who are admitted with exacerbation of COPD multiple times, we should keep an eye on the heart in these patients. We know always that the lung and the heart are fundamentally linked through several things, but what's important, COPD can cause cardiovascular disease through different mechanisms, and cardiovascular disease can cause COPD, can exacerbate COPD can mimic COPD in different mechanisms too. Most importantly, inflammation. Lung inflammation in COPD can trigger systemic inflammation that lead to atherothrombosis and progression of even heart failure, hypertension, arrhythmias, etc. Hyperinflation in COPD can cause problems in blood pumping, as well as hypoxemia, and can cause vasoconstriction, pulmonary hypertension that lead to right heart failure. So precursors of pulmonary and cardiac events can be inflammation, hyperinflation, and hypoxemia. This slide has been shown by Dr. Abdullah, just showing you that many patients seeking care in cardiology, they have an underlying COPD, and untreated or poorly managed COPD worsen cardiovascular prognosis. So it's crucial to take proactive steps to ensure COPD doesn't evade diagnosis in cardiovascular disease. Just a few points from the GOLD COPD documents that exacerbation of COPD is the primary cause of mortality and morbidity in COPD. Recognizing and treating COPD in patients with cardiovascular disease is essential because optimal COPD treatment significantly benefits cardiovascular outcome, and I will show you too in the last slides. Patients with heart failure and worsening dyspnea can be misdiagnosed as pulmonary congestion, and we can miss COPD in these patients, and this will lead to increase in mortality and in these patients and in hospital mortality. For cardiologists, practicing cardiologists, it's important to know that arterial hypertension, heart failure, ischemic heart disease, cardiac arrhythmia, and peripheral artery disease are prevalent and are common in COPD, and they can affect prognosis in these patients through different mechanisms, like in atrial fibrillation is frequent, but not only frequent, it can worsen dyspnea and it can reduce prognosis in these patients. Similarly, ischemic heart disease, because after exacerbation of COPD, there is an increased 90-day mortality from myocardial infarction, ischemic stroke, and intracranial hemorrhage in these patients. And for sure, heart failure exacerbation and the common of heart failure and COPD is important too. So the importance of preventing early death is by treating the exacerbation of COPD, and actually multiple trials have showed, like the IMPACT and ETHOS trial, showing that triple combination therapy with long-acting beta agonist, long-acting muscarinic agonist, and inhaler corticosteroids have shown superiority to just long-acting dual therapy of these patients, which is LABA and LAMA only in these patients. And this not only has shown improvement in COPD improvement and outcome, but also this from the ETHOS post hoc analysis trial have shown that this triple therapy significantly reduced cardiopulmonary events, and I mean by cardiopulmonary events is MACE, severe COPD exacerbation, and death from non-malignant respiratory cause and heart failure. So this is an important thing, that by treating early COPD, we can save MACE in these patients. This is from the GOLD guidelines group, showing that this triple therapy is important in patients who have more than 2 moderate exacerbation or hospitalization with COPD exacerbation in these patients. So COPD independently elevates patient risk of cardiopulmonary events. Early identification of patients at high risk of cardiopulmonary events is critical for the proactive management of COPD, and optimizing COPD management may not only reduce exacerbation, as I showed you, but also there's possibility of subsequent reduction in cardiovascular events and death in this population. This is the publication from the UE group concerning the streamlined referral by establishing a UE-specific referral algorithm. And I can show you that patients, this is the main referral algorithm, that in patients with stable cardiovascular disease, patients with suspected COPD, we have to ask, does the patient have any COPD-related symptoms or risk factors? If no, just treat the cardiovascular disease per se and keep monitoring. If yes, then we have to check the patient has 1 or more COPD risk factors, or the patient has 1 or more symptoms not attributed to heart disease, like recurrent bronchitis, recurrent productive cough, recurrent lower respiratory tract infection, wheezing, and dyspnea. And at the same time, the patient has 1 or more COPD risk factors like smoking more than 10 years, occupational exposure, family genetic history of COPD, history of exacerbation in the past. So these are important as a cardiologist to check these with the patient. If really there is 1 or more of the following, then we have to refer to the pulmonary, perform a spirometry, and confirm COPD in these patients and early treat these patients accordingly. Thank you for the first part, and I think Abdullah will keep the questions for the second part, after the second part. We have, okay. So the second part, already Dr. Firas already have talked about amyloidosis, but this is a AstraZeneca sponsored symposium. Already he discussed about eplontersen, and he mentioned it that it's only in polyneuropathy, but there is an incoming trial that maybe will be indicated also will be positive in cardiac amyloidosis too. Already this has been discussed that ATTR is a multisystemic disease that manifests with multiple constellation of symptoms. We have to have a low threshold to diagnose these. These symptoms can be a neuropathic polyneuropathy, cardiac if it involves the heart, and musculoskeletal, like already has been diagnosed, like carpal tunnel, lumbar spinal stenosis, and ruptured this bicep rupture. Globally, up to 80% of patients with hereditary ATTR can have a mixed phenotype, meaning that it can have polyneuropathy and cardiac disease at the same time. Already this has been mentioned in a different way about the disease-modifying treatment for amyloidosis that include stabilizers like tafamidis and acoramidis, but there are also silencers, RNA silencers, like eplontersen that will be discussed further, vutrisiran and patisiran, but also there are gene editing therapy ongoing, as well as anti-amyloid antibody extracting amyloid from tissues too. So there are multiple modifying risk disease treatment. When we say silencers, meaning that they block the synthesis of TTR from the liver, and this has been showed that from different guidelines and the expert consensus statement that these silencers are the first-line treatment in polyneuropathy, in hereditary ATTR, and as well as mixed phenotype. This is just to show you that there are approved or investigational these are the approved and investigational therapies of transthyretin amyloidosis, and they are divided into hereditary polyneuropathy as well as cardiac amyloidosis. Already Dr. Firas has alluded it well in his lecture, discussed it well, but just to show you that there are multiple approved ATTR polyneuropathy in clinical use. One of them is eplontersen, but also there is ongoing trials in ATTR cardiac amyloidosis, the cardio TT transform trial that hopefully will be published next August in the ESC guidelines. So we have some of these treatments, they can work on both, but some they are only approved in neuropathy. Just so I want to concentrate on the NeuroTT transform study, which evaluated eplontersen in this population of hereditary ATTR polyneuropathy. It's called the NeuroTT transform. It included stage 1 and stage 2 polyneuropathy, meaning they are either ambulatory without assistant or ambulatory with assistant, documented TTR sequence variant, and signs and symptoms of polyneuropathy. They were randomized into a 6:1 ratio of either eplontersen 45 milligrams sub-Q, Q4 weeks, included 144 patients, versus a control group from the inotersen study, previous study, 300 milligrams sub-Q, Q4 hours, 24 patients. After 34 weeks, they shifted them to eplontersen 45 milligram, and they followed up these patients for 5 weeks. And the historical control group, because it's unethical not to give these patient treatment, was from the NeuroTTR, 60 patients in the inotersen group. Key baseline characteristics: the mean age was 53, 4.5 years duration before from the symptoms onset. Most of them were 80% stage 1. They were in 68%, they have previous stabilizer use, and the 60% they have the V30 mutations of the TTR variant, and 34% were having the cardiac involvement in these patients. The primary endpoints were the percentage change in serum TTR, and there are the composite score of neuropathy intervention score plus 7, which one, the higher the poor the prognosis of these patients, and the other, the Norfolk quality of life diabetic neuropathy total score, also the higher score, the higher the percentage. So just saying that there is, with eplontersen, there was significant, rapid and sustained reduction in serum TTR, reaching significant reduction of -70 at 65 weeks, which is comparable to the TTR transform trial, but this was extended till week 85 with a -81% reduction. And it continued sustained reduction up to 3 years of follow-up. Concerning the scores, neuropathy score for quality of life, for symptoms of these patients, we can see that there was significant reduction in the points between the control group as well and the study group by around 25 points, which is significant. Even after 66 weeks, there was an additional 3-point reduction in this group of patients. So eplontersen continued to halt progression of neuropathy through 3 years, and there was a clinically meaningful benefit in the scores at 66 weeks in these patients. Also, the Norfolk quality of life neuropathy score, also the diabetic neuropathy score was significant with around 20 points, which is very significant, with a p-value less than 0.01, and also it remained sustained even at 85 weeks in this population. Just just another sub-study of this trial about the mixed phenotype patient. These are the 1/3 of patients who have cardiac involvement in these patients. They have a similar NT-proBNP and NIHA classification, and basically similar echocardiography parameters, but actually in this population compared to a placebo, the reduction in serum TTR and the improvement in the scores, whether in the neuropathy-only group or the mixed group, it was significant, and it has impacted the outcome in these patients. In addition, there was favoring improvement in ejection fraction and stroke volume in patients on eplontersen compared to placebo in this population, but there was only preservation of the other diastolic and echocardiographic parameters. So globally, up to 80% of patients with hereditary ATTR have mixed phenotype. Eplontersen may attenuate the progression of the cardiac manifestation of hereditary ATTR amyloidosis, but we are waiting the CardioTransform trial. Eplontersen had consistent benefit in halting progression of the neuropathy impairment and improving quality of patients, quality of life in these patients with mixed phenotype 2. Thank you.